Good morning, good afternoon, good evening, good night, wherever you are. Welcome to this 10th TechNet webinar and our second in the Vaccine Data Discovery series organized by JSI and Sonder Design Collective. This human-centered design study is a joint effort between the two organizations and the Ministry of Health in Kenya, aimed at understanding the challenges around collecting and using data for decision-making in delivering immunization services. So I said this is the second in the series. The first webinar in the series took place on June the 18th and was entitled Reframing How We Think About Decision-Making, 3 Lessons from Healthcare Workers and Managers in Kenya. The webinar covered perceptions around who is and is not a decision maker, the context in which decisions are made, and how relevant information is accessed to inform these decisions. If you weren't able to attend, the recording of the first webinar is available on the TechNet 21 YouTube channel. I'll share the link in the chat in a short while. And also the slides and the follow-up discussion from that first webinar can be found in the TechNet Forum discussion page. On to today's webinar. It's entitled The Health System Map and Its Actors, introducing you to the key actors who make up the Kenyan Immunization Program. And we welcome back the 4 panelists who presented our earlier webinar, Isaac Mugoya and Wendy Prosser from JSI, and Emilia Klimiuk and Sarah Hassanen from Sonder Design Collective. During this presentation, you can submit your questions to the panelists in the box in the bottom right of the screen. And if all goes well, we should hopefully have enough time for about 5 or 10 minutes of questions at the end of the presentation. And Wendy will be sharing the slides in the forum discussion page after the webinar ends. I should also say we're recording the webinar and we'll also publish that on the TechNet YouTube channel as soon as possible. So with that, with time being short, as this is only a 30-minute webinar, I'll pass over to the team from Sonder and JSI. Thank you.
Thank you very much for the introduction and for hosting us for this webinar. And thank you for everybody for attending. My name is Emilia with Sonder Design, and I will walk you through some of the intro slides. And so, as we've already kind of explained up in the beginning, the context for this work, we've also spent a little bit more time talking about the human-centered design approach, as well as some more context about the project in the last webinar. So if you're interested in that, feel free to go and reference that video from last week, from 2 weeks ago, sorry. Just very quickly to set the context for this work, as we've already mentioned, the aim of this work is to really look at the system from a user perspective, which is the human-centered design approach, and understand some of the root causes behind a lot of the challenges that you all are familiar with that the immunization community has been grappling with for years. We are conducting this research in 3 countries, Kenya, DRC, and Mozambique. As of now, we have conducted the work already in Kenya, so the discussion today will be based on that research. And just for your reference, the scope of the work was 3 counties, 12 sub-counties, and a total of 84 participants. So with this approach, we don't talk to very many people, but the people we talk to, we spend a lot of time with them, and we do more in-depth personal interactions. So it's less people, more in depth. Move on to the next slide. So as mentioned, the focus this week, as opposed to kind of deep diving into a very specific topic around decision making as we did in the last webinar, this week we want to take a step back and really give you an overview of some of the outputs of our work. So we're going to be introducing you to this system map we've generated, which maps different actors, different roles, and the different tools that are being used for decision making at these various levels of the system. And for today, as we are short on time, we will be focusing on 2 layers of the system. Wendy, you can skip to the next slide, thank you. Which is the sub-county level as well as the facility level. Report that is available for download, you will see that we've kind of mapped out what is the role of each of the layers of the system, who are the key actors, what tools are being used, as well as individual actor profiles for some of the key roles. And I will hand it over to Wendy now to walk us through the facility level.
Great, thanks, Emilia. So I imagine all of you are very familiar with the facility level and the roles and responsibilities and just the different activities that happen there. The primary goal at the facility level is really to provide immunization services, so that one-on-one interactions with moms and babies and all the clients that come in. And it's a lot of data recording, as you know, and data collection, and reporting it to the higher level at the sub-county. It is a core function as long as it's directly linked to immunization services, vaccine stock management, tracking children, tracking dropouts. I think there's a great quote to highlight here. When somebody has so many patients to attend to, they'll concentrate on the patients and not capturing the data. Which I think it's great insight that I think in the immunization world we already know pretty well. And here's just a breakdown of all the facility level actors. So the immunization nurse is there and interacts with the MCH in charge. In Kenya, they have community health volunteers for a lot of the outreach and promotion that the immunization nurse works closely with. And there's a whole network of people that interact to make decisions together, to plan priorities, to identify dropouts and how to reach the most, any missed opportunities for children. So just a quick overview of the facility level tools. I think one interesting thing that came out of this is that there are some formal tools that are provided by national level that are designed and that cascade down, but then there's also a lot of informal tools that healthcare workers have created just as kind of a workaround to make their day a bit easier. And it depends on the different programs. HPV now that is introduced has some specific registration cards and to track. And I think we've all seen those pictures of a nurse sitting at her table with the registry book and with the tally sheet and the stock card and the stock ledgers and the reports and the monthly summary reports all on top with a baby next to her trying to get vaccines. Right, it's this very typical thing where there's a lot of data collection tools that the nurse has to deal with in addition to her regular job of actually caring for children. But the informal tools, I think, was the one thing that really kind of struck me as interesting, that there were these workarounds that health workers created to help track BCG in maternities, for example, or just writing on your hand for the stock instead of putting it on the card because you don't have time in that moment. But all these workarounds that contributed to these formal tools, but in an informal way. And as we know, the nurse does all the data collection. She verifies it's accurate. She tracks all the children across all the different vaccines and across the multiple forms that are required. A lot of the challenges that came up through this research, I think everyone is very familiar with. So they're expected, as a nurse, she's expected to do the reports, but there's not enough time, of course. A big issue that came up is just having the actual paper tools. That if you don't have that, you have to create either from a notebook or a piece of paper to collect the data that is required to report up in this formal system, but you don't have the tools available. And any of the tools are set up for a structured system, and anything that falls out of that or changes, the tools don't exactly adapt to that. So those tools have to be adapted in the moment. So it's that last minute quick decision that nurses have to make to be able to collect the data that is required, even if that tool doesn't fit that structured situation. There's another thing that came up is that nurses, the fourth bullet there, that's I don't have the proper training or passion for numbers, right? So they're required to collect all this data and to analyze and to be able to track children and track vaccine use and administration, but that's not their main passion. So it's almost a mix of two things, and balancing what's required by the system for data management, but then also what's required by the system to care for children. The decision-making, and we talked about this in the last webinar, the decision-making is really a group decision. The nurse will make decisions on just those day-to-day operational, like how to organize a session, how to track the temperature in the fridge, how to manage the children coming in and out. And as a group, it's more the priority, it's the health management team, and it's developing the annual work plan and the health management with the health management team, and that's very big group decisions. And the nurse never sees, when we were doing this the research, the nurses don't see those daily operations as decisions, they just see them as tasks. And then the interesting thing with the outreach is that was really decided by the facility in charge or even the sub-county level. And that the nurse is not directly part of deciding that. And so the sub-county, I will pass to Emilia as we move to the sub-county level.
Thanks, Wendy.
Sectors, certainly.
Great. And so at the sub-county level, we really, based on the research we've done, we really see this as playing a very central role in an immunization program. So I'd like to say they have the facility in charges on speed dial. And so they're able to follow up on any data issues and really clear things up quickly and understand what's going on in the ground. They have a lot of just built-in knowledge about their sub-county, but they're also very in touch with what's happening at the county and even sometimes at the national level, and they're in charge of operationalizing all of those policies that are set at the higher levels. So they're very much an in-between, and they have a lot of influence over kind of setting the standards for data quality, what gets followed up on, what the which policies are actually implemented versus ignored, as well as just informing the overall data culture. So we see this as a very kind of central level in terms of impacting data quality and kind of creating any kind of change in the system. In terms of how they interact with data, again, they're very central. They're aggregating and reporting on data. They're managing data. They're in charge of actually inputting the data into the digital system. They're also doing a lot of the analysis of the data and acting on it directly and kind of implementing changes as a result, working with the facilities. Again, going over to the next slide. Here again, we have an overview of the different players that are at the sub-county level. Here you'll notice that it's actually a very kind of flat structure. So the health management team, what we saw is there's actually a very, very close knit, a lot of collaboration between the various verticals. So the HROH is very closely interacting with all of the other people on the team, and there's almost daily interactions between most of these players. I think because of time, let's move on. Let's talk about the tools. So on the next page, you'll see how much fewer tools there are happening at the sub-county level, and you'll notice most of them are actually tools that are generated or filled out at the facility level, and they're just reviewed at the sub-county. So much less tools, a lot of them very full. I have them listed here, but there's also a series of kind of like less formal impromptu communications that happen, for example, to get ready for meetings and to communicate upwards using WhatsApp. So those are also some additional informal tools that didn't make it onto this list. But either way, there's much less tools that are being used, and most of it relying on kind of the digital. And then I'll walk you through two of the actors we really feel are kind of key to this level, which is the HROH, and then I'll also talk about the EPI Manager. So the HROH, if the sub-county level is kind of central for informing any kind of change to the immunization program, we really felt like the HROH is central to that sub-county level. Again, they're doing a lot of follow-up with the facilities. They're the ones deciding when to follow up on data issues. They're also involved in the majority of the meetings that are happening to make any kind of a decision, because they are responsible for bringing in data. So they're collecting all of the data. They're also feeding all of the data to any major decision-making processes that are happening at the sub-county level, as well as even some on the county level. What you'll see here in terms of challenges is that One of the kind of more surprising ones, I mean, I think as Wendy mentioned, none of these are huge surprises in terms of what the challenges actually are. But I think one thing that stood out to us is really the importance of the availability of tools at the facility level. So this was repeatedly mentioned as a major challenge for the HROs, is the fact that when they're not able to provide tools for the facilities, it creates a motivational issue. So it's really difficult for them to follow up with facilities to submit data or to submit data correctly or to fix any quality issues, because the facilities are coming back to them and saying, well, you haven't given us the tools, why are you asking us for this data? So I think by far this was the biggest challenge for them. The other challenges that, again, not surprising, it has to do with still with the following up on data issues. So there's a lot of issues around not having airtime or not having transport costs to be able to go to the facilities and fix. And then the last two here are related more to the keying in data. So the system is not, the DHIS2 is not very reliable. There's a lot of issues they spoke about in terms of just things not even showing up. So you might have entered information in, and then the next day you come back and you can't find that information. A lot of unpredictable glitches that make it hard for them to trust the system. And then also inconsistency between the paper forms and the digital forms was also very high on the list of challenges. In terms of decision making, I think I've already touched upon a lot of this. I think in terms of the things they decide on their own, and I think this was especially true with some of the more motivated, kind of exceptional HROs, was that they really felt like they were beyond just managing data. It was really their role to analyze the data and then identify any trends and share those trends with their colleagues. So, examples such as even just a quick one outside of the immunization program, one of the HROs spotted there was a trend in obesity levels and, was able to kind of print out a chart and give it to the nutritionist, sitting across the office to be able to come up with a plan to address the issue. So they are very central, and the decisions they make are around when to share data and what data to share. I think that's their core decision they make alone. In terms of decisions they make as part of the group, it's practically all decisions that are made at the sub-county level involve the HRO in one way or another. And then out of their control, again, this is the issue of resources. So are supplies available to record data correctly? Do they have the airtime? Do they have the resources to be able to follow up and do their work? Is largely outside of their scope of control. And let's move on to the EPI Manager at the sub-county level. So in Kenya, this is also the logistician. So this role is largely around managing the cold chain as well as solving any issues related to the cold chain and kind of managing the stock levels. And so there's a lot of what you see with this role and kind of on the practical level is most of their time is taken up by kind of reshuffling resources, talking to the facilities to try to solve any issues around the cold chain or around things being out of stock, and then kind of communicating any issues upwards to get more resources, get that fridge fixed, or whatever other issues they might have. So there's a lot of just logistical things they're doing, and again reshuffling a lot of resources. One of their biggest challenges that I think is really came up over and over again is around having this elaborate planning process and then not really being able to rely on that whatever plan was made, it's almost guaranteed is not going to be followed. So for example, the numbers that are being used for planning are not reliable. And then also once you've created a plan, ordered a set amount of vaccines, and then you discover that the amount of vaccines you ordered for is not available. So you get a different number. So again, you're reshuffling. You've done all the work to approximate how many vaccines you need, and then you get a certain amount of vaccines that's not what you ordered for, and then you're spending a lot of time trying to figure out how to kind of reshuffle those resources and spread them across the facilities you have, and being kind of fair in that process. So that's a really big challenge, and related to that are these stockout issues and unreliable data to use for planning. And I think those are the key. I see we're running kind of short on time. I want to make sure we get a chance to answer some questions. So in terms of the decisions that they're making on their own, it's a lot of kind of the day-to-day management and problem solving that's happening kind of on the fly. And in terms of the decisions as a group, again, it's a lot of the health management team at the sub-county level makes a lot of the decisions together. So they're involved in most of the core decisions that are happening at the sub-county level, specifically also around outreach and kind of target setting. And then in terms of things that are out of their control, I think this is probably very common with the HRO, but maybe even kind of more acute. And it's this inability to have any control over your budget and have control over the resources that you are getting. So you're basically just stuck dealing with what somebody else makes available to you. I think I will stop there and hand it over to Sarah.
Thanks, Emilia, and thanks, Wendy. I just wanted to take the opportunity also to let you know that we're going to be holding another webinar in the next 2 weeks on July 16, and that's about policy versus practice. And this reflects the two decision-making modes that we observed in the field. And this is more about the extensive planning and budgeting activities that generally follow policy versus the reactive and often rapid and informal nature of how decisions are usually made on the ground to respond to usually urgent and unmet needs. So we'll be delving deeper into that in the next 2 weeks. So hopefully you can join us then. And in the TechNet forum after this webinar, we'll be putting in the links to the resources that you'll see there, as well as the slides. So hopefully you can join us for the next webinar as well, and have access to those resources via the forum. Does anyone have any questions that they wanted to send through via the Q&A or the chat box? We can answer them for you in the next 7 minutes. In the meantime, there's one that's come through around data quality and whether or not we saw that a lot that came up as a challenge, and how important we think it is based on sort of the breadth of the system and people we've been talking to. Wendy, did you have? Wendy, Emilia?
I'll jump in here. So one of the things we definitely saw as the biggest issue is around the denominator, and how that impacts, beyond just not having the right data to be able to make decisions. It's actually a motivational issue, especially for the healthcare workers who are being evaluated on their performance based on the targets that are set. And so there's this like very direct comparison that they're able to make to see the denominators that they're getting, and the targets that are as a result they're getting from national versus surveys that they're doing on the ground. And there's a lot of quotes around nurses saying, I'm constantly being kind of reprimanded for not reaching my targets, but I've been to the community, I've talked to the people, I've done that outreach, I know that we're not missing any children. And so that was by far the biggest one. Wendy, I'm not sure if you want to chime in with anything.
Yeah, I think that's the most insightful thing that came out in terms of data quality itself. At the data being collected, we didn't dig into those details. We didn't do like a data quality assessment or anything, but just the amount of tools that a nurse is required to use. Usually just like best practices, the more times you have to record the same numbers, as we all know, the more chances for error. But the denominator is what was the really big issue, and the motivating factor, I think, as Emilia pointed out, was really important.
Thank you, Emilia and Wendy. We have a question here, which I think is something that we've been discussing internally as well, is about the informal data collection workarounds, and wondering whether they are they demonstrating a potential innovation that we could, build upon and maybe even formalize?
And I'll jump in there. For me, that was the biggest insight that came out of this, is that nurses create these workarounds, these informal tools, yet they're not they're not included within the formal system, and they're not recognized. But there are a lot of workarounds that work, that help them do their job, that make the data better and help a nurse be able to track children better. And it's a great question to think about what could be replicated in other places or adapted. And even if it's not the tool itself, the ability for a nurse to make decisions and to adapt a very structured system into her own way of doing things, still within the system and still with respect for the system and policies and standards, but being able to adapt it, that I think would be great to explore a little bit further, to see what is feasible and what's doable and what's allowable, while still maintaining the high standards that we all want, but allowing the flexibility and the innovation to actually drive something forward. I think that's definitely an area to explore and to really support. And so it wouldn't just be the tools itself, but the system itself to support more innovative thinking and creativity to make systems work better, essentially.
Yeah, and I'll just chime in here. Thanks, Wendy. The other thing I think we also saw is that there's, when facilities had an opportunity to meet together with other facilities and with their peers, there was a lot more sharing of innovations across the level. And so in counties where we saw there was funding for those kinds of meetings, there was a little bit more of, I guess, scaling of any kind of innovative tools that were being used. However, there's no examples we've seen where anything got scaled beyond that facility level to be supported at the county level, for example. The other thing I just wanted to very quickly mention, I think in terms of when we're looking at the workarounds, I think there's two things that they point at. On the one hand, some of the workarounds are pointing at the fact that the tools are really not good at supporting decision making. And so a lot of the workaround tools we've seen are kind of helping to make that next step to be able to help the nurses make decisions they need to make as part of their work. And the other one is much simpler and is just kind of a usability issue. So where we start seeing workarounds where a nurse feels too overwhelmed to enter information into a register and is instead writing things on her hand, it's a good indicator that probably that tool needs to be redesigned to be much more simple. Thanks.
Thank you, Wendy and Emilia. I know there's one more question that's come up. There's a few that I have, and any questions that we can't answer now, we're going to answer them on the TechNet forum. So please join us there to continue the conversation. But there was a question here around how the Kenya Ministry of Health has been using this information. And I might just, one way that we already know that it's being used, and this is just the beginning, is as part of their data quality improvement plan. And so we know that a lot of this sort of detailed information, which is even more detailed that you can find in our report through the link, has been used to sort of feed into that plan and start to address some of their strategic thinking in the next couple of years. Dan, thank you.
Thanks. Okay. Well, I guess it's just left for me to wrap up then. We're finishing on time. That's wonderful. I'd like to thank all of our panelists and all attendees, especially those who asked such interesting questions. As Sarah says, I encourage you to continue the conversation on the TechNet forum. Responding to Wendy's original post, or if your perspectives are wider than that, please create your own forum discussion. And before I close, I just remind you that we are having the third in the series on later in July, and we'll be promoting that on our TechNet forum and social media in due time. So with that, I close the webinar and I give you back the rest of your day. Thank you very much, and stay safe. Thank you. Bye.